Hello everyone and welcome to this audio podcast. This audio podcast is part of a Juxta NewsBeat, series or edition. This audio podcast as part of a Bostix Biosphere. This audio podcast as part of a Storm the Bostix production. In this audio podcast, a little bit of a sort of a revisit in around looking at urinary tract infections or UTIs. So, urinary tract infections, or UTIs as they are abbreviated, are a significant cause of morbidity in recipients of all ages. UTIs are caused by both gram-negative and gram-positive bacteria, and by certain fungi as well. The most common causative agent is E. coli or Escherichia coli in recipients with catheters, a broader range of gram-negative bacilli, including Proteus, Klebsiella, and Pseudomonas, are frequently causative organisms in recipients who, for example, are within the population or and within and amongst particular conditions where they, for example, have to dilate their bladders and urinary tract through for example, catheterization. The incidence of UTI is three times larger in CKD CKD recipients who are not on forms of renal replacement therapy, for example, hemodialysis or peritoneal dialysis, than the general population. And the assumption that recurrent UTIs in recipients with vesico-ureteric reflux or VUR lead to renal scarring, and consecutively around chronic kidney disease is sort of understanding context that's within published works and within the literature. And UTI is sort of a first common symptom of anomalies that aligned to particular forms of renal insufficiency and renal malformation, for example, that are aligned to the urinary tract, which in literature has been referred to as congenital abnormalities of the kidneys and urinary tract. So that's CACUT or CAKUT. So the epidemiology around urinary tract infections or UTIs, generally UTIs stem from sort of bacterial infections affecting 150 million people every year, sort of globally or worldwide. UTIs can be a significant cause of morbidity in all ages. In all ages, the most sort of common bacterial infection is in recipients of pediatrics who are aged less than 2 years. Around 43 to 56% of urinary tract infections or UTIs are associated with the use of catheters, where again where some recipients where for example there may well be sort of urinary tract abnormalities or scarring, for example, where and of course with that unfortunately recipients can be susceptible to particular forms of urinary tract infections. So in relating to urinary tract infection sort of classification, there's uncomplicated and there's complicated classifications. So uncomplicated can be denoted as typically where individuals are affected who typically can be healthy and have no structural or neurological urinary tract abnormalities, and infections can be differentiated into lower urinary tract infections, cystitis, for example, and upper urinary tract infections, where pyelonephritis may well be evident. Complicated classification around urinary tract infections are associated with factors that compromise the urinary tract or host defense, including urinary obstruction, urinary retention caused by neurological disease, immunosuppression, renal failure, renal transplantation, pregnancy, and the presence of foreign bodies such as the use of self-dilatation, contraptions, for example, catheters. Atypical UTI, urinary tract infections, is where recipients with oliguria, where they may have evidence of renal insufficiency, abdominal or bladder mass, elevated serum creatinine, septicemia, failure to respond to treatment with suitable antibiotics within 48 hours, infections with other organisms other than Escherichia coli, and so atypical UTI is and can be evident and prevalent or pronounced in recipients with these sort of symptomologies. Clinical features of urinary tract infections. So presentation of urinary tract infections can vary from a range of symptoms, and recipients with limited for example limited clinical symptoms to symptomology where urinary sepsis is evident. Infection of the urinary tract can affect both the lower and upper parts of the urinary tract. Lower urinary tract infection can be defined with symptoms suggested of cystitis, dysuria, or increased urinary frequency with fever, chills, or back pain. Upper upper urinary tract can present with symptoms suggestive of pyelonephritis, where loin pain, flank tenderness, fever, rigors, or other manifestations of systemic inflammatory response are evident. Urosepsis may be diagnosed with clinical symptoms of infection and are accompanied by signs of systemic inflammation, for example, fever, tachycardia, and tachypnea. And catheterized recipients who do not always present with typical clinical symptoms of a urinary tract infection can have particular clinical features that are linked with sort of the different classifications under urinary tract infections. So some of the sort of some of the sort of general risk factors for the different types of urinary tract infections. For the different types of urinary tract infections, both lower and upper urinary tract infections can include poor urine flow, history of previous urinary tract infections, recurrent fever or uncertain origin, excuse me, antenatal diagnosis of renal abnormality, family history of vesicoureteric reflux or VUR in renal disease. Constipation can be a risk factor in those recipients. Dysfunctional voiding, an enlarged bladder, abdominal mass, evidence of spinal lesion, poor growth, and also high blood pressure as well. So, in related to urinary tract infection symptoms, there's urinary tract in this sort of sort of overview. There's the urinary tract sort of area that is affected, and then the signs and symptoms that are related to, that are in regard to that. So, in related to renal, where renal pathophysiology is affected, is linked to pyelonephritis. Where the bladder is affected, is linked to cystitis. Where the urethra or the renal tubules are affected, it relates to urethritis. And the signs and symptoms for pyelonephritis, for example, can relate to upper back and side flank pain, high fever, shaking and chills, nausea and vomiting. With cystitis, it can be pelvic pressure, lower abdomen discomfort, frequent painful urination, and blood or hematuria within the urine upon voiding. And with urethritis, there can be a burning with urination and discharge as well. Then relating to sort of the diagnoses, if you like, is urinary tract infections in recipients may be difficult to diagnose, especially in pediatrics or young people aged less than 2 to 3 years. The symptoms or symptomology and signs in this age group are and can be generally non-specific. Diagnosis in around the diagnosis as well. Urine investigation or urinalysis is warranted in recipients of pediatrics, especially with typical urinary tract symptoms, and in cases, for example, where there's unexplained pyrexia or fever. The modality for diagnosing a urinary tract infection is a clean, voided midstream urine sample. Again, as part of the diagnosis, urinalysis is involved. Microscopic analysis of sort of centrifuge urine, for example, where five white blood cells per high power field is a usual, can be a usual, is a usual, and has been a usual sort of threshold for pyuria. A urinalysis and urine culture can be used to diagnose acute pyelonephritis or APN. And automatic counting of uncentrifuged urine, where for example there's 10 white blood cells within the specimen, can also and is also important. And then as part of diagnosis, having sort of microbiological specimens and cultures in laboratories to appropriately dose, for example, antibiotics if required, if and when required, are important as well. So specifically around the urinalysis now, so urinalysis is helpful for nitrate and leukocyte esterase and microscopic examination for white blood cells or WBCs and bacteria. The nitrate dipstick investigation or analysis represents the conversion of sort of dietary nitrate by gram-negative bacteria and has high specificity, around 98% for urinary tract infections as well. Urinalysis has sort of limitation in that it can give sort of negative results when the bladder is emptied frequently, or if underlying pathogen is gram-positive. Urinalysis dipstick investigation is not recommended for pediatrics or young people who void frequently. And leukocyte esterase has sensitivity of again around 87% of UTIs, and white blood cells or WBCs present in the urine on microscopic examination, which can be a useful indicator of inflammation associated with UTI, and where inflammation is and can be a complication in addition to a UTI. So in related to sort of those microbiological cultures or laboratory investigations, so a urine sample can be cultured to detect bacterial growth in urine, which can be indicative of infection and can guide antibiotic therapy. Urine should be cultured if recipients have 2 or more signs of infections, especially dysuria and pyrexia or fever. Significant bacteria is defined as 5 times 10 to the 4 colony forming units or CFUs per milliliter, so CFU per mil, and recipients with positive urine culture and normal urinalysis without symptoms are regarded as having asymptomatic bacteria. In relating to imaging or for example around radiology, so the main objective of performing imaging following a urinary tract infection is to identify recipients with at least in infants or newborns, or in pediatrics, to identify, for example, to identify etiology that relates to congenital abnormalities of the kidneys and urinary tract, or KCUT, CAKUT, and mainly also in around, for example, mainly, for example, symptomology that also can relate to vesicoureteric reflux, or VUR, who may be more susceptible to recurrent urinary tract infections and renal tract scarring. Abdominal ultrasound is perhaps one of the least invasive diagnostic investigations or tools in evaluating pediatrics with urinary tract infection, and ultrasound is indicated in all recipients with urinary tract infections aged less than 6 months. In around the management, the choice of antibiotic should be based on locally developed current resistant patterns of urinary pathogens. Parenteral treatment is required in pediatrics or young people who are severely ill or unable to retain oral intake, and parenteral antibiotics should be switched to oral as soon as clinical improvement is observed, usually within 24 to 48 hours. And upper urinary tract infection treatment should be, if prescribed, sort of on an average basis, and as in the literature, anything between 7 to 10 days, and in lower urinary tract infection treatment should be around 3 days. So related to the management, recurrent urinary tract infection is defined as 3 or more separate episodes in a given year. Daily antimicrobial or antibiotic prophylaxis has been found or identified to reduce the recurrence of sort of different forms of urinary tract infections, and the guidelines across different health conditions, although can be sort of ambiguous. However, there is evidence to indicate that antibiotics are appropriate between upper and lower UTIs. There is not sort of an ideal prophylactic agent. All antibiotics are associated with increasing resistance and occurrence of adverse effects. Antimicrobial or antibiotic prophylaxis can be used to sort of routinely in specific conditions, for example, congenital abnormalities of the kidneys and urinary tract, or KUT, and have been identified and proven as effective in reducing the risk of recurrent urinary tract infection. Also, in addition, around management, the management aspects around UTI, there's a treatment aspect. So, urine investigation must be performed, or should be performed, before the initiation of any antimicrobial treatment is introduced. UTI treatment should always be in line with local guidelines or based on microbiology investigations, and treatment. Sort of the general treatment, in the literature include antimicrobials. For example, amoxicillin, cefalexin, ciprofloxacin, coamoxiclav, privamicillin, and fosfomycin has been documented as a form of UTI treatment as well. Recipients with fever or pyrexia should be referred may need to be admitted to a hospital if for example, the pyrexia and the fever it also has sort of links with other symptomology that recipients have. And if recipients do not respond to antibiotics or antimicrobials within 24 hours, they must be admitted to hospital because of the possibility of antibiotic resistance. And again, this where recipients may have pyrexia or fever symptomology as well. And a recipient should complete a full course of antimicrobials antibiotics if symptoms are more are not if symptoms do not improve. Um, So, in summary, it's recommended that urinalysis be performed in recipients with typical urinary tract infection symptoms or UTI symptoms, and especially in pediatrics or young recipients with unexplained pyrexia or fever. Urinalysis should be performed also before the administration of any antimicrobials or antibiotics or antibiotics for prophylaxis. Both positive urinalysis and bacteria are necessary in the diagnosis or to diagnose urinary tract infection or UTI. Recipients with positive urine culture and negative urinalysis without symptoms or symptomology are regarded as having asymptomatic bacteria. And in recipients are younger than 3 months of age, for example, in recipients, the differentiation between upper and lower urinary tract infection generally prompts health professionals to implement the appropriate guidelines accordingly.